start the webinar right now. I am Dr. Pauline Chan. I am the unit head for HIV, hepatitis, STIs, and elimination of mother-to-child transmission and TB. And it is my pleasure to welcome you today in this webinar organized by the WHO Southeast Asia Regional Office, CRO. And we today are talking about demystifying Lenacapavir for HIV prevention and looking at the global evidence and early implementation lessons. Now, why did CRO organize this? It was because that in discussion with communities and with partner organizations, we felt that Asia can learn from other regions, and in particular, Africa is now pioneering and leading globally on Lenacapavir or LEN implementation. So for us, it was until the drug comes to Asia, we still have much to learn from the other regions and from other colleagues in other ministries of health in Africa. So without further ado, can you put the housekeeping slides, Pruvi? Thank you. Our objective is to understand the science, the efficacy, present the global guidance and policies, and share implementation experience. And we will discuss the opportunities and challenges and the requirements. So we aim to have this really very practical. Please put your in the chat your questions and comments so that we can address it during the Q&A and in between. Also, the speakers can also address them by chat. Next slide. So this is the agenda where we will have several speakers to go through the whole series of presentations, and you can continue to put questions and comments on chats. Next. This session is being recorded and your attendance is consent to be recorded, and the session materials, including recordings, will be uploaded into the website of WHO CRO. So it's an archive, and then you can use this or circulate it to your other colleagues or networks after the webinar. Next. Questions and chats. Use the chat function regarding the topics or to introduce yourself. So please use the chat to introduce where you're from. Next. And in the data use, we'll be recording, and so we will have some basic information, how many basically will be here. Thank you very much. So without further ado, let's go quickly to the first presenter, which is my dear colleague, Ms. Heather Marie Smith, Dr. Heather Marie Smith, was advisor for HIV prevention program and implementation with UNAIDS, the Global HIV Prevention Coalition Secretariat, and WHO in Geneva, Switzerland. She is also one of the co-authors of the Lenacapavir guidelines. So over to you, Heather Marie.
Thank you so much, Pauline. And I'm just waiting for my slides to go into. Perfect. So good afternoon, everyone, and thank you so much. It's such a pleasure to be with you here to talk about Lenacapavir for HIV prevention, and particularly the global guidance. Next slide, please. So 1 year ago, long-acting injectable Lenacapavir was recommended by WHO. And Len joins 3 other very effective and safe WHO-recommended PrEP products, including 2 other long-acting products. So everybody on this call, I think, probably knows oral PrEP by now. It is the most popular and accessible of the PrEP options available to date. The Demystifying vaginal ring also is a long-acting product, and it's a long-acting vaginal ring. And Cab-LA, so the 2-monthly long-acting injectable. All of these products were recommended on the basis of evidence for effectiveness, safety, community values and preferences, and likely cost effectiveness, among others, and recommended as part of combination and comprehensive HIV prevention approaches. Next slide, please. So when WHO recommended LEN as an additional HIV prevention option, we also recommended that rapid diagnostic tests can be used for long-acting PrEP. However, although HIV self-testing is recommended for use with oral PrEP and the DVR, at this time, there is insufficient evidence to recommend it for use with long-acting injectable PrEP. So please keep that in mind when we're talking about testing for lenacapavir. There will be implementation studies that will look at this role and hopefully will generate the evidence that we need to be able to have that recommendation. Next slide. I do want to take this opportunity very early on in the presentation to be clear that WHO does not support one PrEP product over any other. While we're going to be talking about Len specifically in this webinar, Len is not a silver bullet. And successful introduction will depend on having a robust HIV prevention program within which to integrate Len. It is important that programs offer options because having prevention choices can increase overall prevention coverage. Different PrEP products work for different people at different points in their lives and or with different partners. So really the best PrEP product is the one that somebody wants to use and will use well. Next slide. So looking at the evidence for Len was assessed across a range of countries and populations, including adolescent girls and young women, men who have sex with men and other gender diverse individuals, and demonstrated a high efficacy. In the primary study, there were only 2 breakthrough infections reported in Purpose 2. There were none reported in Purpose 1. Since then, there has been data released at CROI this year, for example, bringing the total number of breakthrough infections to 5. So there have been additional infections in Purpose 1. However, this still leaves us with at least a 96% efficacy, which is very high. The rates of most adverse events were quite similar between lenacapavir and oral PrEP, and most were mild or moderate. The one thing that is a bit different is injection site reaction, and that shouldn't surprise anybody. Len is an injectable, and oral PrEP is not. So injection sites were the most common adverse event, but were typically mild to moderate, and they decreased over time, and they didn't lead to high levels of discontinuation. One thing that is particularly concerning for many clients and also providers is the formation of nodules or induration. And so the nodules are formed from a subcutaneous depot, and this can be visible or it can be palpable, so you can feel it. These resolve more slowly than other injection site reactions, and as I said, can be a particular concern. That said, there is no difference in efficacy or in safety for adolescents aged 16 to 17 years compared with older cohorts, and Len can be safely used in pregnancy and breastfeeding. However, data remain limited for some key populations, such as people who inject drugs. And this is being explicitly explored in Purpose 4, for example, and we're hoping to get results for that soon. The other thing that I forgot to mention is lenacapavir is a first-in-class HIV-1 capsid inhibitor. This means that there is no cross-resistance with other forms of ARVs, and this will be important later. Next slide, please. I do want to touch on the dosing for lenacapavir because it is more than just an injection. We talk about it as an injectable, but it is more than that. So lenacapavir is administered or given as a subcutaneous injection, so just under the skin, and it's administered every 6 months. But at initiation, there is a mandatory oral loading dose. This is non-negotiable. You cannot skip it. So for somebody who is starting lenacapavir, they start with 2 injections, and these are at different sites, usually the thigh, or the abdomen, although there are some alternative sites that are being used in countries. And additionally, that same day, somebody would take 2 oral pills of lenacapavir. The second day, so the day following the injection, they would take 2 more oral tablets. Those tablets on day 1 are needed to reach protective levels within 24 hours. And the tablets on day 2 support the durability of that protection for the first month. Without the oral loading dose, protective levels aren't reached until 3 to 4 weeks after the injection. So this is why it's really important. It's also why, so it's really important that people make sure that they know about that oral loading dose. To continue Len, it is simpler. There are 2 injections every 26 weeks, and the window for coming back is plus or minus 2 weeks. However, if somebody does return late, so they return after 28 weeks, even if it's only 1 day, they do have to restart lenacapavir. This means that timely access to services and a robust recall process are really essential for implementation. Next slide. So the contraindications, interactions, and considerations are pretty similar to other PrEP products. Lenacapavir should be available to anybody who's at risk of HIV acquisition, and individuals who are requesting it should be prioritized. The contraindications are very similar. So somebody who's had a reactive HIV test or HIV has a high suspicion of acute HIV infection shouldn't receive lenacapavir. People who are indicated for PEP, so they've had an exposure within the previous 72 hours, should be offered PEP instead. Obviously, if somebody has an allergy or a contraindication to any of the medicines used for lenacapavir, including lenacapavir itself, it shouldn't be administered. And adolescents should weigh at least 35 kilograms. Len, however, is not contraindicated for anybody who has hepatitis B or C. There is no issue offering it to people with hepatitis B and C. There are few drug-drug interactions and contraindications. However, the use of some medications at the same time as lenacapavir or in the 9 months after stopping lenacapavir might require a dose adjustment. The most important of those is in the treatment of TB, and particularly rifampicin. So the US label and most of the African labels, I think all of the African labels, do allow for lenacapavir administration with rifampicin. And usually there is a dose adjustment that is required for lenacapavir. However, other labels like the EMA do have a contraindication for use. So this is something that's decided very much by local regulatory agencies on a case-by-case basis. Additionally, there is some interactions with some anticonvulsants, some illicit or recreational drugs like ketamine, or some erectile dysfunction drugs, which I know often form part of the party packs for chemsex, for example. So this is something to be aware of. Lenacapavir is not expected, however, to interact with hormonal contraceptives or gender-affirming hormones, which is a big relief. Next slide, please. I know a lot of clinicians and people generally are worried about breakthrough infections and also drug resistance. So, as I mentioned earlier, 5 breakthrough infections have been reported to date, and 4 of those showed drug resistance. However, lenacapavir as a first-in-class antiretroviral that is not used widely for treatment, because it's not used widely for treatment, the public health impact is currently very limited. However, ongoing surveillance is needed. Next slide. And we have really good evidence to suggest that lenacapavir is acceptable to communities and individuals, providers, and also is feasible for implementation. And my colleagues will talk a lot more about this later in the webinar. But very briefly, between 2/3 and 3/4 of participants across Purpose 1 and Purpose 2 preferred lenacapavir. And this was in Purpose 1, for example, at 12 months. So they'd had experience with injectables by this stage. In the PrEP Appeal study, which was across 17 Asia-Pacific countries, about a third of MSM and transgender women were willing to use lenacapavir, and about 20% had this as their top preference. Of course, this was in a context where lenacapavir was still very unknown, and we also had a bunch of other products that we were looking at the same time. What is very clear is that individuals find that injectable PrEP is more convenient and it has a fit with their lifestyle, that there is the potential for discreet use, which is another thing that they really like. People are more confident with maintaining adherence or protection with an injectable, and they're more reassured around effectiveness. There is a clear preference for less frequent dosing when it comes to any PrEP product, but particularly when it comes to injectables. And this is, of course, natural because it's a reduced burden on the person who is receiving it. The concerns also varied a lot by setting. So concerns that would need to be dealt with in promotion, but also in counseling, include injection-related pain and other potential side effects, scheduling challenges to make sure that people can get back for their doses, and of course, cost is a major driver. Next slide, please. So I wanted to just quickly zoom out to where lenacapavir is globally at the moment. Programmatic implementation has now begun in 9 countries, and the first 2 countries, Zambia and Eswatini, began in December last year. But you can see across that there have been 9 countries now that have launched, and a 10th launch is expected in Malawi next week. Altogether, there have been more than 25,000 initiations across 8 of those countries, which is phenomenal in such a short period of time. And the first follow-up visits began in May. So it's still very early to see the data. In total, there will be 24 countries that will receive lenacapavir between the end of 2025 and early 2027. And these include several countries within Asia Pacific, such as Thailand, Indonesia, the Philippines, Papua New Guinea, and Fiji. And I know that there are several others that are preparing for lenacapavir with their GC8 applications. Next slide. Lenacapavir introduction is about more than just the product. The product is important, but it's not everything. And so there really does need to be a consideration of all of the other things that are involved. We do need really rapid introduction at a sufficient scale to achieve impact. As I've mentioned choice before, I want to reemphasize that offering Lent as a choice and integrating it as part of comprehensive prevention approaches is going to be critical for success. Provided training should include choice counseling, for example, to help that. Also dealing with switching, adverse events, client recall. There is a risk of remedicalizing PrEP, and so efforts should be taken to maintain differentiated service delivery options and further expand them. In Asia Pacific, we've done an amazing job with oral PrEP in many countries in having very good differentiated service delivery options. We can't lose that with Len. So we have to work out how do we best integrate it, and you'll hear examples later. Comprehensive sensitization for stigma and discrimination-free service delivery. We still know that that's a problem in all of our services. And monitoring and surveillance systems should be adapted to incorporate lenacapavir, with specific efforts around monitoring for adverse events in pregnancy and breastfeeding, for toxicity, seroconversions and drug resistance, and also CLM for quality improvement. It should go without saying, but we have to say it. Funded community mobilization, awareness raising, and demand generation activities are crucial, as is the full participation of communities in designing, implementing, and monitoring programs. And of course, there are a lot of resources already available that can be leveraged to speed up preparation. Next slide. Len does have enormous potential if it's scaled up as part of a robust HIV prevention response. So modeling indicates that lenacapavir, and this is modeling, all models are wrong, some models are useful, But modeling indicates that Len could avert up to 45% of new HIV infections if it's offered to almost 60% of people from key populations in a concentrated epidemic like the Philippines with a higher HIV incidence. Providing Len to one person could save more than the lifetime treatment costs if it is priced at about 40 to 60 US dollars, which is similar to what is projected for generic pricing, which is good news. And if it's targeted to a population with an annual incidence of over 1%. But local target setting and modeling for impact and for costs are needed to have a look at what this looks like in the local context. Next slide. There are a range of resources available to support introduction, and I will provide these slides after the webinar. Last slide, please. So I want to end by saying that Len has enormous potential to increase HIV prevention coverage if it's offered as a choice. It's acceptable, it's efficacious, it's safe, and it's long-lasting. It can also be more convenient, discreet, and support adherence and effective use. It is not a silver bullet. It won't fix access issues, and in fact, it could exacerbate them because programs have to have on-time client recall as part of their systems. And it relies on a comprehensive and robust HIV prevention and testing program. Quality programmatic rollout has to be the goal. So consider phased implementation, not a pilot to speed up access, promote sustainability and community leadership. And Len introduction should leverage the lessons from oral PrEP and CAB-LA. And we have already early lessons from Lenacapavir in other countries. So that equitable access, demand, supporting DSD, integration, broad access, choice, and looking at opportunities for innovation. And the last slide, I just want to say thank you to Sierra, to Pauline, and to Purvi for organizing the webinar, and to thank everybody, every one of you on this call for your continued work in making PrEP happen. Thank you.
Thanks very much, Heather. I mean, the presentation really certainly triggers some ideas and thoughts as well. But without further ado, let's move on to the next speaker, which is from Gitten. And Gitten is our dear friend and colleague, and he is the Community and Policy Program Manager at MFA's Treat Asia program in Bangkok, Thailand, and has been championing community advocacy, access to medicines for a very long time, and an incredibly well-known person in this area of HIV and related response. So over to you, Gitten.
Thank you so much, Pauline. Yes. Thank you so much, Pauline, and a very good afternoon to everyone. Much of our discussions so far and deliberations on HIV prevention and also for treatment has been focused on the long-acting products. And as Heather Mary just pointed out, there has been quite a bit of work that has been done by WHO and others, and also implementation coming out from Africa region that is leading and allowing the process to go on and to expand further. So I'm going to talk briefly for the next 10 minutes around the regulatory approvals. I'm not going to talk just about Lenacapavir, but also a prior product that has been available even in our region also, that is long-acting cabotegravir, and also give you some of my thoughts as we go on. So as Heather Mary pointed out, we have had the guidelines, the normative guidelines that has come out from WHO, which is on long-acting cabotegravir in 2022, and then very recently we have had the Lenacapavir related guidance from WHO that allows countries to understand what the recommendations are and for them to consider and start using it, adapting it, or adopting it in terms of utilizing those recommendations as part of their national programs. To enable this to happen, we have to recall that there has been products that has come out from the voluntary licenses. In 2022, around the time of the voluntary license, around the time of the WHO guidance, we have had the voluntary license from VIV with the medicines patent pool on cabotegravir. And in 2024, Gilead signed a bilateral license with 6 companies, 4 from India and 1 from Pakistan and another 1 from Egypt. So this would allow, complementing the policy, this would allow the generic products to come out, and then the low and middle income countries that are part of a license and the ones that are not part of the license, with negotiations with either the originator or whatever the conditions would be to access this. But primarily the target is on the countries that are included in the voluntary license. So we have had licenses both for cabotegravir and also for lenacapavir. For cabotegravir specifically, we have had 6 countries so far that has approved the product. 7 so far, sorry. So 7 we have had so far in the region in Asia Pacific that has approved cabotegravir. Cambodia, Dr. Bora is here and he will talk more about experiences as he gives his presentation, is also utilizing, with support from the Global Fund from Grant Cycle 7, they're implementing a program. What is interesting is I think this is the first product for HIV that the ASEAN Joint Assessment process was utilized, where 5 national regulators participated, and Philippines leading it. But what was also a little bit of a concern was the time taken in this joint assessment, that it took almost a year from the start of the joint assessment. So it started in June 2022 and ended around May 2023. And Vietnam, very recently, I think it's around January, that they approved cabotegravir. So despite having a joint assessment program, it has taken a lot of time, but it did bring together national regulators to approve this product. And also, VIV Healthcare has been providing what they call as their access pricing. And this has been applicable for low-income and least developed countries and sub-Saharan Africa. There are certain conditions to this, but in 2025, the product was available for $20 per injection. That is slightly more than what is being projected at the moment for lenacapavir, but this excess pricing has been made available low income and less developed countries. So there are not many countries in Asia Pacific that would qualify for this. But VIV has always said that they're open to negotiations in terms of product pricing and making the products accessible should national government want to utilize cabotegravir as a part of the national program. So that door is always open. On the other hand, cabotegravir is right now available in the private market. It's in those countries, and some of the countries, not all the 6 countries, but it's quite expensive. The oral 1-month leading dose, that is generally not recommended, but if it is given by someone or prescribed to somebody, that's around $316, and 7 injections over a period in Thailand would cost around $3,200. Similar in Malaysia, it would cost around $3,600. So for someone with a kind of income that we have, especially among the people that needs this medication, the price is something that has always been raising a kind of a flag in terms of affordability in the private market. And in the public market, as I had just mentioned, outside of Cambodia, there has been no other country that is implementing or utilizing cabotegravir. Coming specifically to lenacapavir, the time frame is really interesting to follow. October 2024, that was the time when the voluntary license was signed. But to note again that countries, upper middle income countries like Malaysia in our region, has been excluded from this license. Around 7 months in July 2025, post the voluntary license signing, Global Fund signed an agreement with Gilead Sciences, where 9 countries were identified as earlier presented as early adopters. And in that time, 2 million people was a kind of ambition that was cited to cover over a period of 3 years. So that was up until, I think, 2027 that they plan to cover 2 million. In September 2025, just after a couple of months, PEPFAR announced support to HIV high burden countries. In that time, Philippines was the only country that was included from the Asia Pacific. Then in September again, that same year, a partnership between United Gates Foundation, CHAI, had identified 2 countries that had said that they would supply Lenacapavir at $40 per person per year. So this is what countries would be able to purchase at if the generics, as and when the generics are in the position to supply post their regulatory approvals. The first year, as Hida Mary pointed out, will need 4 tablets in the initial one. So that would be approximately $15. So year 1 would be $55, and the subsequent years would be around $40 per person per year. That's predicted. That's predicted at the moment. But the moment the number of people who are on lenacapavir goes up, the higher the consumption, the lower the price is going to be. So it's important to keep that factor in mind. Very recently, Global Fund, PEPFAR, and Gilead added 12 countries. And from the 2 million ambition that they had mentioned in July 2025, they've now said that to 3 million by 2028. And of the 12 countries, there are 4 in Asia Pacific, which is Fiji, Indonesia, PNG, and Thailand. They were added to that list very recently. In terms of the regulatory status in Asia Pacific for lenacapavir, this is what Gilead had actually prioritized 18 countries when they signed the license in 2024. So Thailand, Philippines, and Vietnam were included in the list of prioritized countries for the regulatory related, marketing related registration. And now they have fulfilled that. And Philippines, Thailand, Vietnam all have been filed the registration dossier sometime in December 2025, Philippines recently in February, from Gilead. So that this is something that is progressive in terms of what Gilead committed to in 2024. Recently in April, also the Global Fund had issued expression of interest for product evaluation by their expert review panel, which means that the products that are qualified by or that are approved by the expert review panel would be able to be purchased utilizing Global Fund grants. So this is another positive development that is happening for global procurements. Very recently in mid-June, right now, I mean, very recently, as in right now, what is happening is the Indian regulators have filed for WHO pre-qualification, the US tentative approval, and also for the registration in India with the CDSCO, which is like the FDA in what's known the similar acronym that they use here in India. And they have filed for this. So these are the things that are ongoing at this point. In African countries, some of the distributors of the Indian generics have filed for registration of the generics. They've started the process utilizing the information that they have utilized for the generics have utilized for the WHO pre-qualification process. So things are moving, but not to the speed that we would want, at least as in Africa. So we would have to wait for a bit of time, both for the originator and also for the generics to come into the market. Now, we talk quite a bit about cabotegravir, dapivirine. That's not very much in use in our region, as I understand, outside of Philippines and Cambodia. But there are other things that are coming up in the market also. I'd like to mention those a little bit also. Beyond, the first thing is be it cabotegravir or be it lenacapavir, It's not just drug pricing or the regulatory approvals. For the government, and there are maybe colleagues that are from Department of Health or Ministry of Health who would utilize this as part of a national program. Beyond those drug pricing and regulatory approvals, I think investment on the health system planning, development of guidelines, infrastructure-related development, manpower training, since these are injectables, these are really important things that we have to keep in mind when we start considering these products to be a part of our national programs. And I think the earlier, the better it is for us. We also have the once monthly Lenacapavir, which is known as also MK-8527. I think this brand name has not been really made public, I think, but you'd find this if you do a literature search in the internet. But this is another one that's going to really change on how we look at HIV prevention. It has a 1 hour onset, so the moment you take a tablet now, and that means after an hour it starts working, and it is once a month. So it would be maybe something that's very easy to integrate in our existing PrEP programs, or something, even if there are no existing PrEP program, or where there are pilot programs running, it would be something easy to start with without investment on infrastructure. It will also help in terms of demedicalizing, decentralizing, and also perhaps, to be more discreet, and also change with the 1 hour onset of how we define on-demand PrEP at this point. So that's something that we can look at and start planning. This is subject to the current phase 3 trials ongoing at this point. 4 countries, 11 sites in the Asia Pacific region. So we are also working with the sites and also with Merck, make sure that enough data is available and appropriate data is available as and when it comes to the generic, should there be a voluntary license, and Indian companies are part of that license. What we are also missing out is people who inject drugs, or people who inject drugs. 18% around 55 to 60 million of people who use drugs are in Asia Pacific, of which 5 million are opiate users. And we have long-acting depo-buprenorphine that is either recommended as a once weekly injection or once monthly injection. So people don't have to come back to the OAT center every day to take, the sublingual buprenorphine. And recently, WHO has, the full guidelines hasn't come out, but WHO is also recommending long-acting depo-buprenorphine. Unitaid is doing some work around, understanding this product better at this point. So this is something that is in the pipeline. All the trials on long-acting products for HIV prevention have not included so far people who inject drugs or people who use drugs, except for purpose 4 on Lenacapavir. But to my understanding, that's not testing the efficacy of the drug, but on the pharmacokinetics of Lenacapavir among people who inject drugs. So we have to also start talking about access to long-acting depo-buprenorphine for the 5 million people or beyond that could benefit. There are certain limitations in terms of manufacturers and who can actually, given the nature of the medication, but there has to be discussions on access and market shaping initiatives, just like how it has been done for cabotegravir and also for Lenacapavir. Thank you very much, and I'll be happy to take questions. I would have to leave, unfortunately, very soon, but please put in any questions in the chat, and my colleague Pauline and Purvi will take those questions, and I'll be happy to answer as far as I could, or whatever information that is available at this point. Thank you very much to everyone, Pauline and Purvi, and the rest of our panel members. Over to you, Pauline.
Thank you, Keaton. And for the very early questions on access, because there was a question from Nepal whether there's access to cabotegravir or to Lenacapavir at this time. Do you know about the registration process at all?
what I mentioned about at this point, cabotegravir is not registered in Nepal. We will be having a meeting with the Nepal civil society and key population groups on the 15th of July in Kathmandu to basically discuss about this. But at this point, unfortunately, it is not available or registered at this point. But as I said, if the Nepal government is interested, at least for cabotegravir at this point, Nepal is a low-income country, so they can negotiate with VIV directly to get the excess price, which is around $20. And by 2026, I think they might have gone down also. So that opportunity is there. So it's for NCSC and also for the civil society and other physician groups to come together and discuss, see the relevance of this, and request NCSC to approach VIV. I will be happy to answer any further questions on that. But that option definitely for Nepal is open. Thank you.
What just before you go, what you also point out basically is that there's still a body of work to accelerate and pre-discuss with programs in ministries and partners and communities and donors and the Global Fund, how to introduce accelerated access for Asian countries, because Africa is leading. I'm blown away by the numbers that they accelerated just so fast in 9 countries. So Asia is indeed lagging behind in access. Over to you.
Yeah, absolutely. Yeah, so the Dr. Leot is also here, so he will be talking about Zambia and how they approve the product and all of those sort of things. So we are very, very actually they approve in terms of number of days, like even the national regulatory approvals. And for us, if we look at Thailand or for Vietnam, where it has been filed, we have been like at least it has been 6 months. So there are a few things where we can improve on. For that, we all have to collectively work together with our FDAs to make sure, and also with the companies to make sure that all the registration dossier is complete and it's in a position where we could get access to this as early as possible. Absolutely, we need to do that.
Thank you. So moving on to, it's with pleasure to invite Dr. Loyal Mulenga from Zambia. And Dr. Mulenga is an internal medicine and infectious disease physician serving as the director of the infectious disease for the Zambian Ministry of Health. Now, Gitten, Dr. Mulenga, Gitten has said that you have put accelerate in the word accelerate in a matter of days. So we are all ears now. Over to you, Professor. We see that we have some IT issues. Dr. Mulligan said that she cannot see the option for audio. So can the IT please work on the option to make him a panelist?
Neeraj, can you help in unmuting Dr. Lloyd?
So please keep the questions coming in on chat. And as you can see, there's a lot of exciting developments in the whole long-acting HIV prevention options. There's cabotegravir, the LEN is here, and then also the MK product, which is also coming as an oral monthly drug. So, and also with long-acting buprenorphine as well for those who inject drugs. So it would be really interesting to see how that discussion can happen inside countries, and of course to reach out to WHO and UNAIDS to help catalyze also the support to countries as well. Dr. Mulenga, can you get into it or not? Normally there's a panelist link. If not, shall we start off with Dr. Barbara Mambo from the Kenyan while we sort out the IT issues with Dr. Mulenga from Zambia? So Dr. Barbara Mambo is the head of HIV prevention at the Division of National AIDS and STI Control Program, Ministry of Health, Kenya. So with pleasure, Dr. Barbara, over to you. We are really keen to hear from you. Thank you. As a pioneering country.
Thank you very much. Greetings everyone. Where I am, it's still morning, it's 11:15. And thank you very much for this invitation to take part in this webinar. So my name is Dr. Barbara Mambo. I work for the Ministry of Health in Kenya. That is the National AIDS and STI program. I lead the HIV prevention section. So I will share Kenya's early experience introducing Lenacapavir or Len for HIV prevention. I'll focus on 3 things. What gave Kenya the confidence to launch, what opportunities and early successes we have seen, and what challenges have emerged as we move from introduction to scale up. So the core message from Kenya is very simple. Strong readiness and strong demand are essential, but they are not enough. For LEN to have impact, countries must also stabilize their service quality, preserve real-time prep choice, strengthen community engagement, and use your data carefully to guide scale up. Next slide, please. So Kenya's experience may be useful to colleagues in Asia because LEN was introduced through a government-led public health program and not as an isolated research product or a parallel service. There are 4 parts of the Kenyan experience that are particularly transferable. First, that LEN was layered onto an existing PrEP and HIV prevention platform. Second is the rollout was phased and targeted. We didn't go everywhere at once. Third, Kenya used the national system for commodities, for reporting, for safety monitoring and supervision. We did not try and introduce parallel systems to be able to do this. And fourth, we have learned very quickly that what looks strong at launch still needs to be tested through real service delivery. So this presentation is not a perfect implementation story. It is a practical early adopter case study about what countries may need to anticipate when moving from readiness to implementation. Next slide. Okay, so the first point is that Kenya did not introduce LEN into an empty system. Oral PrEP had already provided a national delivery platform, and long-acting products were being positioned as part of the broader prevention choice agenda. So we had already started putting it in our guidelines. So we had oral PrEP in our guidelines since 2016, and we have been rolling it out over the years. So before launch, Kenya had a policy guideline work underway, which we eventually launched at the beginning of this year. And we also had a phased operational plan. We did a readiness assessment of the facilities, and we also did a lot of provider training and EMR preparation. So the principle was to integrate LEN into existing MOH systems wherever possible. The foundation mattered. It helped Kenya launch quickly, and it gave the counties. So we have a devolved system. We have our national system, that's the National Health, where I work with the Ministry of Health. And then we have a devolved county system where we have 47 counties that deliver health services. So the launch gave counties a structure to work through, but it also taught us an important lesson. Readiness at national level, which is where we were, does not automatically mean quality at the point of care. That is why a post-launch supportive supervision became so important for us to be able to see what was happening in real time on the ground. So next slide. So before launch, we had a readiness assessment done. We had a tool that we disseminated, we sent down to the county teams and had them go through it on their own and sort of evaluate where they are in terms of readiness. The readiness assessment was very useful because it showed us 2 things at the same time. First, Kenya had strong structural readiness. That was true. 178 facilities were assessed across 15 of the phase 1 counties. We had selected 15 counties, and the overall readiness score was 86%, which is actually very, very good. So infrastructure, lab systems, M&E systems were strong enough to support the launch. But then the assessment also identified a major vulnerability. Community engagement and IC readiness was only at 44% at the time of the assessment, and this was all pre-launch. So this was the most important early warning. it showed that the limiting factor for uptake might not be what is happening at the facility, but whether the communities understood the product, whether they trusted it, and if they had clear pathways into services. So for countries that are now planning for LEN introduction, this distinction matters. Readiness to launch is not the same as readiness to generate demand or to sustain it. Next slide. So for our rollout design and early progress, we used a phased and targeted rollout. Phase 1 counties and facilities were prioritized based on factors such as the HIV burden. If we have a presence of priority populations seeking services within that area, if we have an existing PrEP platform, existing oral PrEP platform, and the strength of the EMR. So we use electronic medical records in at least above 90% of our facilities, although we still have facilities that are paper-based. But for us to do our rollout, it was one of the requirements that we have a strong EMR base because we wanted to actually get real-time data on how counties were performing. So by evaluation done on 10th of May, by our data on 10th of May, LEN had reached at least 162 facilities and 5,760 people had already been initiated. By this time, I believe we have already reached a number of 8,000 who have been initiated on LEN. And of this number, we had at least 969 who are pregnant and breastfeeding women. So more than 3,900 providers had been trained in long-acting PrEP delivery and reporting. And another thing that we did is that we rolled out 2 products at the same time, 2 long-acting products. We rolled out LEN and we also rolled out CAB. So we had 3 PrEP choice products, that was CAB-LA, LEN, and oral PrEP. So these early figures showed that demand was real and the rollout had traction. But they also brought a question. Could the delivery system keep up with demand while maintaining quality, safety, data integrity, and PrEP choice? Next slide. So Kenya's early rollout was not a failure story, not at all. There were several very clear strengths. Facilities reported very strong client interests. In many sites, injectable PrEP had been integrated into the outpatient departments and also into the maternal clinics. Providers and PrEP focal persons were committed and actively supporting implementation. Also, our data platforms showed that EMR reporting systems were already in place, and even if they still required strengthening, because we had weekly check-in meetings with our county teams. But the opportunity here is bigger than LEN alone. At National, we have come to say that LEN is fixing our prevention space a day at a time. So the LEN introduction can strengthen the whole HIV prevention platform, because remember, it's not being offered in isolation, it's being offered as part of combination prevention package. So it can improve PrEP choice counseling, it can improve routine integration into maternal and primary care services, it can improve provider mentorship, data quality, and also community engagement. So for countries preparing for rollout, it is useful to ask not only how many clients are we going to initiate, but also how can this product strengthen our wider prevention system. Next slide. So once rollout began, the main implementation gaps appeared at the point where the product met the provider, the client, and the routine health system. So the first challenge was provider practice and choice counseling. We had this whole plan that it will be within PrEP choice, and some providers needed more confidence on injectable PrEP options. They needed more information on switching and counseling for true product choice. The second integration was for pregnant and breastfeeding women. In some sites, uptake was affected by provider hesitation, client concerns, weak MNCH integration, or access barriers. The third challenge was data quality. Facility records, pharmacy records, EMR, and national warehouse data did not always align. So we had established a dashboard, which was supposed to show us real time how we were able to, how many patients were being, how many clients were being initiated. But during our weekly check-in meetings with our county teams, we soon came to realize that there was a disconnect about how the the providers were putting in the data into the national data warehouse. And so a lot of the times we had gaps in what our data was saying. So it did not always align. Our data did not always align. Fourth, pharmacovigilance. The reporting was inconsistent in some sites. And fifth, the community linkage was still quite weak with IEC gaps. We still had a lot of myths, people talking about it causing, was it impotency? Some people talking about it as a vaccine. And it also limited a lot of uptake and referral tracking. So the key question is that the problem was not the absence of the planning, it was that planning inputs had not yet converted uniformly into field performance. Next slide. So commodity pressure is one of the most important lessons for Kenya. The introductory land quantities they were finite from the beginning, meaning we did not have enough stocks for everyone. Already from the start, we were starting from a point of less product for the demand. Based on our modeling and our quantification, we knew we needed a lot more land than what we received. So the demand in many facilities were very, very strong, especially when we put our product within the reach of the targeted communities, the key populations. The targets really flew off the shelf. The commodities really flew off the shelf. So initial facility allocations were rapidly used up. In our view, this should not be framed as an unexpected national stockout, which is something that even yesterday we had in the headlines that, oh, we have run out of PrEP product, but that is not true. The more accurate framing is rapid exhaustion of initial facility allocations within a constrained phased introduction. And the language matters because we have to go back and now speak again to our journalists and our editors, because it keeps the focus on stewardship and not failure. When the public sees such reports, then it will affect how they perceive the program. So the response should be to preserve PrEP choice. Because remember, we had rolled out Kabele, we had rolled out Len, and we still had oral PrEP. And these they still remain active options. We did not try to overspeak one product over the other, but now they're sort of acting as fallback products. So countries should avoid ad hoc redistribution and use only verified facility uptake. And stock data needs to guide allocation. For new products, supply planning and demand generation must be linked from the start. Next slide. So the readiness assessment showed community and IEC as the weakest domain, but it is important to interpret this carefully. It does not mean that Kenya had done no community work. We actually had. We had already involved community representatives in planning, in the IEC review and validation, and we had also developed a lay provider toolkit and a training package. So we have community health promoters and peer educators, and we also have a group of providers called the Mentor Mothers, who were part of this approach to help bring in the community. But the gap was uneven field penetration and weak measurement. Some facilities still had limited IEC materials, the myths persisted, and community to facility referral tracking was not strong enough. The scale-up opportunity is therefore to move beyond awareness. Countries need to track whether community activities generate referrals, whether referrals reach the facilities, and whether clients initiate and if they choose to continue. We hope to see our first revisits for LEN. We started in March. So by August, we want to be able to see if we will still get the clients coming back for their repeat dose. Next slide. So technical supportive supervision was one of our most useful tools in Kenya's early rollout. Initially, we had virtual sessions weekly with the counties, and we kept on trying to fix the problems as they're reported, but it really came to light that technical teams needed to go down to the facilities and do not just an inspection. We designed it to be real-time quality intervention. So the teams observed practice, they provided on-job training, they reconciled data when they were in the facilities, and they developed action plans with the facility teams. So we had one of our facilities called the Magena Sub-County Hospital, and it illustrates this example very well. The facility had demand, and they already had demand. They had integration within the maternal child clinic, but no pregnant or breastfeeding woman had been started on PrEP. This was because the providers were hesitant. The facility in charge then decided to lead a very targeted CME, that's like a webinar, and identified eligible pregnant women, provided counseling, and demonstrated LEN administration while the staff observed. So what happened? Uptake amongst the pregnant and breastfeeding women increased from 0 to 30 within 2 weeks. So 22 to 30 within a very short time. So this lesson is not that every barrier is structural. Sometimes the barrier is provider confidence, and targeted mentorship can change practice very quickly. Next slide. So how would I summarize Kenya's early lessons? And I will summarize it into these 7 points. First, build on existing PrEP systems and avoid making LEN a standalone program. Second, separate readiness from performance. A site can be ready to launch and still need intensive quality support after the launch. Third, invest early in community readiness. I see trust building, myth correction must not come after demand problems have already appeared. Fourth, we need to train for competence, not only for attendance. Fifth, we need to preserve true PrEP choice across the prevention basket, meaning that there's no product that is to be superior to the other. Sixth, we have to validate data before using it for allocation or for scale-up decisions. And seventh, scale with supply discipline, especially when the introductory quantities are not going to match your demand or your needs. So the practical rule is this: readiness enables launch, supervision enables quality, community engagement enables uptake, and commodity discipline protects scale. So I believe now the next slide is my last slide. So Kenya's immediate priority is to stabilize the quality in phase 1, continuing readiness for, and while we continue planning readiness for the next phase. This means strengthening provider competency, service integration, infection prevention control, and PrEP choice counseling. It means that protecting clients already initiated through due lists and confidential recall systems. We are also emphasizing data reconciliation using our data systems and our EMR reports, but validating them against registers, pharmacy records, bin guards, and before any allocation or decisions are made. Community systems must also be scaled through lay provider model, dialogues, referral tracking, and myth correction. Finally, even as we are continuing with the readiness of phase 2, but we are holding commodity deployment should be linked to verified utilization and available supply. So the main reflection from Kenya is that LEN introduction is an opportunity to strengthen HIV prevention systems, but only if countries invest in quality, community trust, data integration, and choice from the start. And I thank you so much for your attention.
Thank you, Dr. Barbara. And that's a very strong ending as well, and a key takeaway. And it reminds me that it's a discipline when you plan for rollout, when supplies are limited. It reminds me of the introduction of HIV DAAs for HIV cure. There was a big run about it as well, and well, facilities ran out of drugs, or well, exhausted their drugs. And even in the space where in the initial part of HIV with introduction of ART, there was also short supplies with patients on waiting lists in many countries all over the world. So there is actually lessons to learn also from the past in terms of trying to roll out and introduce new rollout of new molecules. Thank you very much, and excellent. And please remain online, and please look at the questions because there are several. So without further ado, I would like to invite Dr. Loyal Mulenga from Zambia. Dr. Mulenga is the Director of the Infectious Disease. Over to you, Dr. Loyal.
Thank you so much, and good morning and good afternoon. As my colleague from Kenya as presented, there is similarity in the rollout of lane between Zambia and Kenya. We can go to the next slide. So we started rolling out PrEP in 2017, and that's when we started with oral PrEP. Then in 2024, February, we launched Cable as the first long-acting injectable, and we rolled out Lane on 1st December of last year. But also lately in April, we did introduce DVR as one of the options. So we have 4 options. We have oral PrEP, then we have Cable, we have Lane, and also we have DVR. Although DVR is only in 3 sites. The next slide. So the rollout for Lane was based on the experiences and also the roadmap that we had with long-acting injectable PrEP using CAB. And we saw the reason that we needed to invest in this was because of the low persistence on oral PrEP, but also there was high demand from the communities and also the service delivery opportunities, which we saw looking at community platforms and enabling structures like the PrEP task force, which was driving the technical input and also community engagements as well. The next slide. We were one of the first lane movers. 1st December, Zambia and Eswatini started rolling out lane. And again, what was encouraging is that this was really about 18 months from the trial results to the first dose being in the country. And our target has been about around 82,000 individuals to be initiated by the end of 2026. And we have planned for 542 facilities. But this has been adjusted because of the availability of the commodities, as Kenya has highlighted as well. And we are targeting also pregnant and breastfeeding women as one of the priority groups. And we hope that we will be able to achieve that if we especially introduce the generics. The next slide. We have 4 partners who are helping support the lane introduction and also the scale up. We have 22,000 individuals to be supported from the Global Fund, and all the commodities that we have had so far has been from the Global Fund, where we've received around 13,000. And the PEPFAR, the USG, supporting 52,000 individuals, then United supporting 6,000 individuals for 2026. We have a clear roadmap for preparatory activities which were in place before the launch, and this has continued after the launch. And the task force, which looks at all these modalities for PrEP, has also been in place and steering the country in how we need to move and also refine certain strategies as we go on. The next slide. This was the day that we launched LANE, and it was a gentleman who was the first recipient of LANE. And as I earlier indicated, we based this on the implementation lessons we had from Cablero out. And we first started with 3 initial sites, and we are glad that we started with 3 initial sites, especially with the challenges that we encountered with the commodities. Next slide. We have also looked at the delivery models, which I think many countries need to look at as they roll out LANE, is how do we provide the facility-based services, using those facility-based services as hubs, but also looking at how do you provide services at lower levels. Can we use community health assistants? Can we use the peers who are trained to deliver LANE? And also, can we empower private hospitals, private pharmacies, private clinics as well to deliver some of these products, because we think that if we roll out at community level, then we are going to have an impact with some of our recipients who are not willing to come to facilities. And this is the model which we're implementing. We've started with private pharmacies. We've started with private hospitals. Of course, the main service delivery is in the public facilities. And we also have gone as low as the health posts as well. The next slide. And this slide, we just wanted to look at the challenges which we have encountered as a country because of the dosages. Initially, we received 500 doses, and we are done largely within the first 4 weeks. And we started now rationing. This was just in 3 sites. So when we received an extra 13,000 in January, we saw that again, you had a rise in the numbers of individuals that were getting Len, with the men being in blue, and also the pink being the female. And again, when we were reaching April, the doses reduced as well. So we had again to start reducing the number, deliberately making those choices, the number of people who can access Len. And despite the fact that we had all 3 modalities, we had oral PrEP, we had CAB, and we had Len, we saw there was a high demand for Len, and we needed again to make adjustments at facility level on how many doses can be given. So you see that this has been the struggle over these 6 months in trying to see how many people that we can initiate at the facilities. I can report that the last 3 weeks, we have been now seeing those that have been coming for the 6 months injection, for those that are coming for the re-injection. And we also needed to have commodities available for those individuals. So that management is very important, because you can blow out all the stocks that you have. And when the recipients come for the next dose, if you are not ready for them, because the commodity is not available, that will disrupt the service, and it will also lead to loss of confidence by the recipients of care. The next slide. This, we just wanted to show how the populations have been. You see that a majority of the uptake has been between the age group of 20 to 39 across both genders, male, female. Then we have adolescent girls and young women, female sex workers, but we have a number of people who don't identify themselves in any of those subpopulations. And some may be coming from those subpopulations, but do not identify themselves as FSWs or MSMs, and they are safer to be just included in that general population. But we think there is a high intersection of these subpopulations with those that are covered under the general population. The next slide. The maternal health units is where we have also deliberately tried to roll out Len, and also encouraging most of the pregnant and breastfeeding women. We see that the total female clients in our have formed about 59% of all Len initiations, but we are making headways into the pregnant and breastfeeding population with integration into the antenatal clinics and also the postnatal settings. The next slide. Another interesting finding we have had is that 84% of Len clients are those who are naive to PrEP, meaning that the options which were available before were not suiting every individual who needed access to PrEP. So we have had oral PrEP, we have had CAB PrEP as well, but we still see majority of the people are those who are PrEP naive, who are reporting to the facilities. The next slide. And this is just showing our pharmacovigilance, which is embedded in our systems, where we see a number of people that are complaining or coming with any adverse events. They're coming in with injection site reactions, like the swellings and also nodules, and a few whom we have seen with some ulcerations as well. And injection site pain has been one of the reported adverse event. Some have complained abdominal pains as well. The next slide just shows I think, to pictures of some of the women who have developed some ulcers, and there are a few as well who have developed just nodules without ulcerations as well. And that's why we need to keep on emphasizing on injection technique and also just educating our people that you may have a few of these adverse events and you need to manage them appropriately. None of these have led to any serious medical intervention. None of them have led to adding any treatment besides just supportive management, and including the nodules and also those where we have pain with some mild painkillers. The next slide. So over this period that we've been implementing LAN, we see that the speed is possible, but also it can be fragile. We need, first of all, political support, but we need to be certain that we can maintain this, and we can also be we have to be certain that we need to pass through the bottlenecks and how do we make sure that the staff are trained? How do we make sure that we navigate these challenges we have with supply? And also, how do we integrate most of these services into the antenatal settings and also postnatal settings? We've also seen that choice is feasible. We just need to quantify appropriately for which population may need to be on oral PrEP, on CAB, on LAN, on DVR, and that's why we need investments into understanding what drives choice among our recipients of care, and that there is no single delivery model which can satisfy the community needs. We need to have pharmacies, mobile clinics, community models to be tested is very key. But also equity has to be designed in the program. How do we reach the adolescent girls and young women, the key populations, and also the pregnant and breastfeeding women? Our enabling factors has been the strong political will, the stakeholder engagement. The community has been very key in trying to have LAN rolled out, and also continuous capacity building for the healthcare workers. I think we believe that decentralization and demedicalization is possible. That's why investments in community level access routes is important, and also demand generation. But this demand generation has to be married with what is available in terms of the commodities. We hope that with the generics coming, this issue of not having the commodities will be a thing of the past. Thank you so much. This has been our lesson from Zambia. Thank you.
Thank you, Dr. Law. Again, you and Dr. Barbara have afforded us a valuable insight into the early implementation. Please also check the questions, because I can see that there's a lot of questions on implementation itself that is targeted towards Zambia and also to Kenya. Please have a look. And also request to share your materials, how you have your readiness checklist and the materials of how you scale up. So we'll reach you after after the webinar to try to get your material so that it could be shared broadly for countries to have a look and in Asia and to adapt perhaps, so that we don't have to start to reinvent the wheel again. So without further ado, with pleasure, I would like to invite Dr. Ngoc Bora from NCHARTS Cambodia. And he is the Deputy Director of the National Center for HIV, AIDS, Dermatology and STD in Cambodia. And he is in charge of the national response, HIV response, particularly in prevention, care and treatment. Over to you, Dr. Bora. Cambodia is one of the few countries in Asia that is actually implementing long-acting CAB. Thank you. Can you check, Dr. Bora? I don't hear you. Dr. Bora?
Oh, yes. It clear now.
Yes. Okay. Thank you. Over to you.
Good afternoon, everyone. Yeah, on behalf of HIV program in Cambodia, I would like to share our journey to our program over here. And I have four content that plan to introduce. One is HIV response in Cambodia related to case of PrEP and result of PrEP implementation as of May of 2026. And Cambodia experience with the CAP-LA and roadmap for land PrEP introducing is a strategic game change. For the HIV response, in case Cambodia has achieved major success in HIV response and also become the first country in Asia Pacific that reached in the 95 target. And also country that nearly universal treatment coverage, when it's almost all diagnosed on HIV and ART, and about 98% achieve viral suppression. And it has also reduced new HIV infection by 90% since 1998 and driven and community-based program. And while Cambodia has made significant achievement, but the new infection among key population aged between 15 to 24 years old still high, that need our effort to continue for sustain and progress for ending it in the end of 2013. And for PrEP evolution, we have two steps of introduce our PrEP. Since 2019 to 2021, we introduced oral PrEP. And from 2022 to 2024, we have introduced a community delivery PrEP. And from 2025 to 2027, we will introduce the land include CAP-PrEP. This talk about the service in our country, that we have a lot of significant street in HIV prevention through our national program that roll out for PrEP. And recently we introduced CAP-PrEP and DVO PrEP. We also map the major milestone in the country for HIV response that complement the existing oral PrEP service that we has been available since 2019. Now we see at the result that up to May of 2026, we have active PrEP 59,500 at the end of this quarter. And of course, we have like active and enrolled even on PrEP. So for the active, we sustain only 22,565. This the result come up from 38 PrEP health facility and 24 CBO PrEP site. We also can share and understand for comparing between the result of provide PrEP enrollment and refill PrEP for facility and community we still see that the community is still improve and better than facility. And also the oral drug can retention oral drug as of 2035, we see that more than 12 months, only 30%, and among 33% in 12 months, and 9 months 40%, and 6 months 54%. For comeback for long acting, we also have a plan since WHO has a recommendation 2022, and after that we have prepare for CAP LA in the end of 2023. So we start scaling up until now. And we have a pilot site and implement site and scaling up. Up to now, 2026, we will scaling up to another province in the bordering of Cambodia province. And so. And the pathway of CAPRAP, we also have a step to do for phase 1 for preparation and implementation strategy. Because of all the phase, we have to start for launching or preparing from the pilot side, and scaling up side. And more of target population that we provide prop is MSM, TG, EW, and include the PV people. And of course, the service have integrated with the existing facility because we set up like hub and satellite. So our facility, ALT facility, we set up like a hub that can provide to the satellite. That satellite is include the CBO product. And for the result, we also can see the since we start up to now, we the number of cases is 917 cases for CAPRAP at the May of 2026. And if we divide in the group, most of those are MSM, and 60% are MSM, and 10% TG, and 19% EW, and 11% in the general population. We also thinking that all of those this done because of have a community lead empowering that have to improve those cases like that. We can see the principle of nothing for them without them. So community lead ensure those most effects are at the forefront of decision making and fostering ownership and inclusively. And also the active participant from the trust that can engagement beyond observation and allow for genuine leadership, which that can increase program and relevant participant for trust. And addressing the unique need that the community-driven strategy highlighted by WHO that effectively tackle specific challenging and improve health outcome. And in this implementation, we also have some challenging that while our Cambodia have expanded rapidly, the key challenge remain can reach young key population that reducing stigma and ensuring the adherence and sustaining fund and service delivery innovation. So for PrEP coverage remain low at 34% of the key population estimate with limited uptake of PrEP and DVO PrEP, and for LEN not yet. Yeah. And retention low, only 33% during the month 12. And PrEP awareness among key population community still low, and insufficient fund to support PrEP, including reimbursement and CBO PrEP budget. This addressing challenge can make to challenging and solution by we need to increase the PrEP coverage to 50% among our census people, and meet the annual PrEP enrollment target by scaling up CBO drop-in center and integrate PrEP into all AIT clinic and other service, example like maternity or family health somehow, and expand our delivery channel like tele PrEP or mobile PrEP, and PrEP choice, oral or daily on demand, and cap PrEP and DVO PrEP with community building. And we ensure study by support of PrEP commodity, oral PrEP, cap DVO, and self-test kit. And will drive community demand creation with behavior change, clinical support, and whole monthly and quarterly meeting at national and provincial level, and roll out the land and all current cap site and booster demand through CBO. And we also sought to improve the retention and refill by allow tele refill every other visit for oral PrEP, and strengthen the PrEP real-time database with a refill notification and adherent reminder. With CBO and CNM, we understand the reason for drop out and run the re-engagement strategy and friendly service and CNM meeting. Also, we plan to integrate PrEP into the HIV meeting agenda at the operational district level or prevention level about the CNM forum or reduce the drop out. Yeah. And provide physical and virtual technical support, respond via the PrEP Telegram group, and hold semi-annual network meeting to review progress and share lesson learned. And we'll introduce the LAN to reduce the clinic visit and easy retention challenges. And regarding to the how to improve the PrEP awareness among key population community, we plan to boost CBO leading PrEP promotion via social media, community, and pop-up event, and a campaign on Facebook, Grindr, and improve a network, and strengthen the CBO clinic collaboration on demand creation, planning, or implementation, and run routine refresher training on board for a new OW, and document on the film-based PrEP provider and cap PrEP and the DVO user, and share this best practice across the PrEP site, and will add land to PrEP awareness and promotion among key population community. So come back for the our roadmap for land preparation introduction as a game changer. We plan to have provide assessment on land acceptability on May or June 2026. And the land prop will in the purchase in this plan to this month.
Dr. Bora, could I ask you to wrap up soon because we are running quite over
Yes.
time. Thank you.
This is my last slide. Yes.
Thank you.
Thank you, Colin. And we at December we plan to develop our SOP regarding to how to introduce the lab land and curriculum, how to promote rising somehow, and introduce the ALT clinic, so center that can have to experience for CAP prep to move to the land. And the land will start in July 2027, and we will expand it up to 2028. I think thank you for this, Pauline and Ubi. Yes, thank you so much.
Thank you, Dr. Bora. I mean, this is an excellent comprehensive narrative of the valuable implementing experience of Cambodia. Having said that, in Asia, very few countries have actually done a long-acting CARB even. And very many countries have piloted oral PrEP, but not really scaled up enough as well. So without further ado, we will invite the India to share their experience. There are two different presentations because they are also fundamentally structured differently. So the first from India is what oral PrEP has taught us preparing for the next generation of HIV prevention. And without further ado, the first speaker is Murugesan Siva Subramaniam is the Chief Operating Officer of the Humsafar Trust. It is India's oldest LGBTQ plus community-led organization, and he currently oversees Project Prepare. So over to you, Mr. Murugesan.
Thank you, Dr. Pauline and colleagues at WHO for giving this opportunity to talk about the project. So just to, while we have been listening to all the presenters, I would just want the participants to also change a bit of a gaze, because what I'm going to talk about is a community-led model, which is like we have listened ministries and others talk, but this is a project that is implemented by the community-based organization. And we also use a very virtual-based intervention model. So you'll not see clinics or facility services delivery in this presentation. So just an heads up as we move along. So this is a project that's supported by Elton John, and we are one of the knowledge partners to implement this. It's an 18 months project. So the findings, the research, the experiences will come based on our experiences from the 18 months. So we all know that India. Next, please. We all know that India, we just have only oral PrEP so far. And, as Gitan mentioned, it's only in mid-June, they've applied for the LAN renewal or the LAN application process for registration. So we'll have to wait and watch what's happening. So the current scenario, like from 2021, 22, we had a lot of private players coming into the picture and were you providing PrEP. But then a lot of community people started asking us, why not community-based organizations like us start delivering PrEP? And that's how we started initiating this concept, and we worked around this. So, yeah. So this project is just to reach out, as Dr. Bora also mentioned, because there was not much awareness among the communities. So we thought that we need to focus on creating awareness among the communities, demand generation, to create an ecosystem for PrEP delivery mechanisms, ensure the supply chain, the health facilities, and the private doctor engagements, to ensure that the project continue. The project is strengthened, and we sustain it even after a lot point of time. And as we get registrations to start integrating LAN, CABLA, and other prevention models or PrEP doses as it comes into the picture. So we are trying to work closely with the CBOs across the country, because we feel that CBOs in future can also start delivering PrEP from their own local areas, and India is very big. So we wanted to also use this opportunity to train CBOs for PrEP delivery. Next, please. So I'll just take a little more time to talk about this. So this is entirely virtual. So this is kind of a faceless intervention, if I would call it, or where we do not see anybody on the ground. So what we do is, like Dr. Bora was mentioning, that we need to use Grindr, Facebook, Instagram. So we do all the outreach. We do demand generation on our virtual spaces, where we reach out to populations and talk to them, provide them information and counseling, and when they talk about PrEP, we do give some information on PrEP. And when they are willing to take PrEP, we refer them to a private lab or a government lab, based on what their needs are or how comfortable they are. So once they go to the labs, they have to undergo the private testing facilities, and once that's done, then we refer them to so once we get the results of their HIV test and other tests, so we do an online doctor consultation. And once the doctor's consultation is done, and once they make the payment, then we courier the medicines to their house. So everything is door to door, end to end. No physical interactions, nothing needed, but the follow-ups, everything happens virtual. Documentations are taken virtual, consent is taken virtual, and we also ensure that the doctor consultations also are regular and also are done virtual. For doing that, we also have an MI system that helps us to know who's ready for follow-up, who needs a follow-up test, and there is a continuous engagement between our virtual navigator, the person who talks to the clients, and the client, to ensure that they are following up, and they're also providing adherence and retention. Next, please. Yeah, so this is just a landscape of the social media that I just discussed about Google search, ChatGPT options, different social media options. We work closely with Grindr for Equality to talk about HIV testing and PrEP promotions. We use community influencers because we need to build the trust as we move along in the communities. One of the key things the key unique feature of this project is, a lot of people who are there are not linked to any current HIV programs that's being run in the country. So, they are usually online. They're looking for online support, so you see a lot of first timers who have tested here. So in a way, we are trying to see that hopefully if this strengthens more, we can reach the first 95 targets, some pieces of it, I would say, not the entire, but contribute to the first 95, if I was to mention correctly. So we do tap these populations who are not part of the traditional HIV programs. So we use party, social media, and different community activities to ensure that we reach those who are not yet reached by the current programs. And these are some of the ads that we use so that we reach like tier 2, tier 3 cities, and the reach is wide enough. Next, please. So this is just a post that we, when WHO had posted the Lenacapavir in July 2025. I just wanted you to take a view on the views. A lot of followers were following, but the non-followers were very high, which means that people who were following the page were interested, but they also forwarded it to other community members who were following it up, and who had interest in this. So definitely, just to highlight that Len is also being what the community is also looking for Len to be introduced in India, and there is some curiosity and awareness around Len as it comes through. Next, please. So some statistics, I would say that we have reached around 27,000 people who have got their HIV test. Out of this, 1,700 have initiated PrEP. So we do see a dropout. We do see people coming for tests, but then eventually dropping out or taking some more time to get into PrEP, because it's choice that we offer them. Sometimes they go to doctors, and then after talking to doctors, they think that they're not at enough high risk for PrEP, so they drop out. So we do see a dropout as we move along. But the key thing to see is that we have seen around 6% positivity rate, among this population. So we are able to tap the niche population, as we are moving forward in this project. Next, please. STI is another panel test that we do. So people who have undergone all the panel tests, including STIs, we see a 10% STI rate. So it's definitely an important indicator that we see we are reaching the high risk population. This is the first time they've got to know that they're STI positive. So we are able to link them to treatment. And I think, not only HIV, further prevention, but also for STIs. I think this is a good mechanism where PrEP can be used. PrEP program can be used as an advocacy to reach the first timers, high risk population who have high prevalence of HIV and STIs. But one thing that we saw is that when people followed up after 3 months or 6 months, we saw 13 people who were negative at baseline, like 0.7%, were tested positive for STIs in the subsequent follow-ups. So perhaps, regular screening, regular treatment, regular discount, regular counseling is definitely going to be important. And I feel that PrEP is just not a pill, but a package that we need to talk about. A lot of different condom use, combination approaches, mental health, and regular screening and testing as we move along, including partner notification, partner testing. Just to talk a lot about overall challenges, client fatigue. People. That's what I was liking this MIK4, which talks about one month, one pill a month. So something like that perhaps will help us, because the current existing guidelines that we follow from NACO technical guidelines, it requires 0, 1, 3, 6, 9, 12. So a lot of repeat tests can lead to client effect, which ensures adherence. People, not everybody is risky throughout the year. So, lack of sexual activity can motivate them to stop and then restart. So, that's one population that we're also seeing. Currently, people have to pay out of pocket for their the blood works and the medicines also. So it's around $5 that we have got negotiated rate from pharmas, and but still that's sometimes huge for them. Because it's courier, and in some rural areas, in small setting areas, our lab person cannot go and get testing there because they do not have the facilities. Sometimes the courier doesn't go there. Like last time we had somebody in Leh Ladakh, so we were trying to find out how to deliver the medicines there. Sometimes the medicines go and they are not at home, and then the medicines come back to us. So a lot of challenges, issues, things like that. And sometimes people just say that, oh, today my trip is finishing. Can you send me tomorrow? So that logistical challenges also we have to face as we move along. With the new Trump regulations, LGBTQI, DNI are being targeted very heavily. So, targeting the high risk populations becomes difficult. So we have to do more generalized ads, which often leads to high costs and affects our digital outreach. So, the targeting becomes less is very difficult. So, we have to reach a generalized approach. Yes, I think we all have heard about CAB-LA and different medicines to work around. So I hope as we move along and more licensing is produced in India and more generic drugs, we will be able to offer multiple choice options than the existing oral PrEP that we have. My last slide, next please. Just some highlights. We have seen zero HIV reactivity rates, and that's one good thing that we have seen. We have built an ecosystem of 50 LGBTQ friendly doctors across the country, so that people in the local states. India is a big state with different regions, religion, with languages. So people who want to know to speak to a doctor in their own language, they can reach to the local doctors. Definitely, Grinder for Equality and other people are coming on board to take this forward and see how we can reach out to the last mile. I think one of the key things that we have faced is that definitely only when people are aware, then only they can come and take medicines, or they can take informed choices of being on PrEP or not. So we realized that a lot of community consultations is required with specific groups. We have done specifically with MSM, one group targeted transgender women with another group. Now we're going to do with youths. So a lot of information and trying to see how we can, take inputs and strengthen the ongoing project, not only for the current project, but also to move forward with sustainability and how we can advocate with the national program to PrEP to be included as a combination prevention choice in the upcoming national program strategy or to the next global fund rounds. So yeah, some experiences that's going to has been useful with strong community engagement and strong community inputs to advocate for a larger PrEP inclusion in the program, and also for the participants to give them an additional choice as they all need it. Yeah. Thank you for your time and understanding. Thank you.
Thank you, Dr. Thank you, Mr. Murugesh. And it's really important because India in CRO is one of the biggest community as well. So without further ado, because we'll be running slightly late on the program, we have two more very important speakers. And then we have one from India, which entirely different model of services, and also from Thailand that is leading cutting edge also in the WHO region in terms of PrEP. So I would like to invite Nihal Raval, which is the program lead at India HIV Alliance, and he has more than 2 decades of experience in HIV prevention and community systems. Then he will talk about Project Spectrum. Over to you, Navral.
Thank you, Dr. Pauline, and thank you, Dr. Purvi, also for inviting us for this very important webinar. So we have this, okay, I'm not able to see the slide, but anyway, I'll continue. We have this project called Project Spectrum. We are reaching out to basically this is looking at the entire speakers, team of speakers and all. India is actually just, at the very starting level in terms of PrEP implementation. I'm not able to see the slides on the screen.
Dr. Pauline, can you confirm if you're able to see slides?
Cannot see your slides.
Can you see them now?
Not yet.
Yeah. Might be a delay. Yes, okay.
Okay, that's fine. So yeah, so the program is again implemented, funded by IJA Elton John Foundation, same as Humsafar Trust, who has just presented now. This is one of the unique implementation, as I would say, because we are reaching out to sexualized substance users among the MSM and transgender communities in India. Right now, we are piloting in 5 cities, including Amritsar, Delhi, Bangalore, Chennai, and Ahmedabad, which is covering almost all all region of India. Our main objective is to reach out to these sexualized substance users, their risk, and how it's correlated to the PrEP. Apart from the reaching out to the sexualized substance users and offer them the PrEP, we also wanted to go ahead and check out the their harms and the risk prediction through PrEP uptake, as well as the adherences and other issues amongst these sexual substance use for the PrEP. How the PrEP implementation is working out amongst them in terms of their sexual behavior and the substance use behavior is the key objective of the program. Also to educate and strengthen the capacity of the service providers in and around the implementation area. Next, please. So the model is we have a hub model where we have 5 physically hub settled clinic at 5 sites. Basically, we're reaching out to the substance users among the MSM and transgender communities, identify them, register them, and offer them a PrEP and other harm reduction services. In that, over here, the main point I just wanted to bring out is that it's the PrEP is paid by the client, and all the tests and everything we get it done through the government facilities. So while going to the government facilities, it has its own challenges also. Once we have this test and everything done, the client comes back to the our hub where we have our counselor as well as doctor and a nurse. All of them would they go through the proper. We follow national guidelines as well as WHO guidelines for the PrEP protocols, which is as mentioned by Murugesh earlier, 0, 1 month, 3 months, 6 months regular test, and the panel test which require. Apart from that, once the PrEP dispensation happens at the club, at the clinic hub, what we do is the 15-day follow-up, one by our community facilitator and one by the community counselor. So in 1 month, 2 times we reach out to the client for their follow-up. In that follow-up, we basically assess their sexual behavior as well as the substance use behavior. And we are tracking their outcome and then plan the counseling models based on the findings. Next, please. So this is the overall glance. What we have reached around 6,000 people. This is around 10. It's the implementation is almost 10 months old. Our beneficiaries are around 3,400 plus. Out of that, all 3,400 plus have been tested for HIV. Out of that, almost 78% are first-time HIV testers, which brings us to the point that you know how this program is contributing to the first 95. The positivity yield is around 1.7. And out of this 3,419, 1,343 people have been initiated on the PrEP. Out of this 1,343 people who have been initiated on the PrEP, what we have seen is the adherence or the retention, if I may say, not the adherence, but if I could use a retention, more than 42% actually drop down at the first month, immediately after the first month. And then the rest 58 are, bifurcated. So we have 32% of them who have taken more than 3 months, and we count as a retained. Someone who has taken more than 3 or more than 3 months refill, we count them as a retained on PrEP. And in that we have almost 32%, which is I think is what the international percentage also. It's around 30% retention what we see in oral PrEP. Next, please. So while we do this longitudinal follow-up with the client, 782 clients have been put it on this cohort. On this longitudinal follow-up, which is every 15 days. In that, I'm just sharing one site, which is Delhi's interesting findings over here. The condom use, which is the major, kind of fear in someone who is the PrEP user, that how's the condom use is coming out. And this is very interesting that condom use have kind of increased at the time of from August to October. People who were using always condom was 8.5. Most of the time were 39.3. Sometimes were 29.2 and not at all. Someone who was not using condom was 15.3. So someone who was not using condom, which is 15.3, has decreased to 6.3. So almost 9 to 10% of them who were not using condom have started using condoms. And people who were using condoms sometimes have also reduced to 8.8, which is the huge difference. People who were using condom always, which is 8.5%, have increased to the almost 16% of them have started using condom always. So, and most of the time condom usage is increased from 40% almost to 77%. So condom usage we have seen this increased in the condom use, which is the basically increase in the risk behavior reduction also. Our overall risk behavior was around 44.5, which is reduced to the 15.1%. And Almost 58% of client have been, followed more than 3 months. So this is the findings. Next slide, please. Very quickly, I will just looking at the time, I'll just go through our major learning. One of the major learning is not that not everyone require long-term prep. The duration obviously varies on the individual risk profile. Particularly with dealing with substance users, it always is that the risk is perceived by a self-perseverance. I mean, client would just say that we do not need any prep anymore because we do not have we do not follow any high risk behavior. 70% of the beneficiaries were client were the first time HIV testers, as I mentioned earlier. Interestingly, people who have been tested at the baseline, then the first month and 3 months and 6 months, as of now, zero HIV and STI infection recorded amongst the active PrEP users. Someone who has been with us for more than 3 months, and it's very interesting that no HIV or STI infection have been recorded. Condom use and safer sex behavior change have been observed within not immediate, but it takes nothing less than 3 to 5 months of a consistent follow-up, and that's how we saw the recorded the change. And the continuation of, as I've earlier mentioned, continuation of PrEP is also driven by the self-perceptions. Is that a client decides that we do not need. The challenges which I'm going to mention is the very limited awareness of PrEP protocols. There is lot many people know about PrEP, but they do not know about the protocols. And the moment they come and join the implementation, they realize that, oh, there are a lot of protocols that need to be followed, and that is one a major hindrance for them to follow. Because in our experience, we've reached out to 3,000 plus people. All of them, most of them have knew about the PrEP, but when they've been told about the entire protocol, they would taken by surprise. They said, "Oh, we thought that there was one pill which you have to take, and we will be, saved from the HIV." So that is something is we need to work at the ground level, particularly in India. There is a very high demand of event-driven PrEP, which is we call it as a PrEP on demand. Basically, most of the people who have left at the first month, we have checked with them, and they said, "We just wanted for 1 year. I wanted to go for this particular party, or my risk behavior was for the particular time." So this risk, so event-driven PrEP is high in demand. But we do not, unfortunately, in India, we do not have the entire setup in terms of packaging for just for two to one. Is the packaging and everything we do not have that. Stigma linked to the PrEP is still there. We have seen this, the bottle which is we provide is very similar to the one with the ART available in India. So people who just say, "Oh, I will not take this because either you change us, give us on some other bottle branding, because I've been targeted as that I'm taking some medicine regularly, as if I'm taking ART." Maintaining compliances with baseline panel tests when follow-up investigations is also difficult, because it's every time we call them 15 days, and then we have to tell them to go for test for 1 month, then 3 months, and then 6 months is slightly tedious for the client to have this so much of follow-up. The financial barrier is obviously there, even though we provide them as a social marketing pricing. Client would always request us to get us some discount on the we basically procure it at 399 rupees at a social marketing price, and we offer them the same price as 399. So, and the cost which is related to their baseline as well as the follow-up investigation reports are also an additional cost to the client if they are not going into the government. And logistic and supply expenses are there if someone is not there, even though we have this hub facility where we prefer client to come and collect there, so then we can do their follow up in person. If that doesn't happen, then we may have to send them and arrange some courier services for that. Whatever expenses is also kind of hindrance. What we are looking at is that the way forward maybe for India is that it has to be combination of PrEP and other prevention model. We need to kind of increase the PrEP accessibility and formalize it protocols in terms of this baseline and other follow-up investigations. Also scale up the SSU counseling alongside the PrEP. SSU is the sexual substance user counseling. It needs a very specific counseling for the client who are sexualized substance use, and obviously the community awareness for reducing the stigma, and importance of sexualized substance use intervention in the national program. And I stop myself over here. And thank you all WHO people for giving us this important platform to present our case. Thank you.
Thank you, Nehal. And important because you also added to the whole realm that it is about combination HIV prevention, and it's an ecosystem in itself. And it is important. And thank you for sharing the really important data around condom improvement, because it's not just about the drugs, it's also about the other forms of protection. So our last speaker is from Thailand, and he is Dr. Jakapatara Bunrang or Fair, and is the medical team lead at the Institute of HIV Research and Innovation, IHRI. Please, Dr. Bunrang, the floor is yours.
Thank you very much, Pauline. And thank you very much, the organizing team, for inviting me to give a talk today. Today, I'm going to share with you the PrEP landscape in Thailand and insights into the implementation studies that the country has planned for the rollout and the scale-up of Lenacapavir injection as PrEP. Next slides, please. So before moving forward, I would like to express the conflict of interest here. Our institute, IHRI, has been supported by the Clear Science through the Purpose 2 study. And without further ado, next slide, please. Let me share with you a bit about the current PrEP landscape in Thailand. This slide shows the principles of PrEP implementation in Thailand, both in the past and also in the future to come. The principle is first, demedicalizations, which is to make PrEP and its delivery as non-clinical as they can be while maintaining the standard of care. In Thailand, we successfully translated PrEP service from hospital-based setting to the community-based setting through the program called the Key Population-Led Health Services, and we will talk about that more in detail in the next few slides. The second principle is simplify or simplification, which is to find a less complex ways to deliver care. The prime examples for this is to incorporate HIV self-testing as part of the PrEP initiation and follow-up. So instead of bringing clients into the clinic or the hospitals, we can now allow our clients to get PrEP without having to leave their home. And lastly, differentiation. We believe that the clients who came in for HIV prevention or treatment requires a more in-depth care that resonates with their specific needs. For example, using gender-affirming care as a gateway for trans and gender-diverse individuals to enter the healthcare system while also incorporating HIV, PrEP, and ART services for them. Next slide, please. So these principles were greatly reflected through the success story of the Princess PrEP program and how we can translate this demonstration project to a more sustainable, domestically funded PrEP program. Princess PrEP is a 3-year demonstration project that allows trained lay providers, most of whom are from the key populations, to provide PrEP for free with a physician's teleconsultations. The project has been proven successful in initiating PrEP and maintaining it among the key populations. Next slide, please. After the program finished, the continuous effort were invested to advocate for policy change that allow this program to be domestically funded. To achieve this, the program needs to be proven replicable and able to accommodate national scale-up. And through this lens, the lay providers training curriculum was created. This training was accredited by the Ministry of Public Health to ensure that standardized care is provided to the clients. And now we have almost 100 lay providers who have been trained and accredited to provide PrEP care. Currently, almost 60% of the current PrEP users receive the services through this initiative. To the next slide, please. So why is it so important to learn about our PrEP landscape? Because this knowledge will be pivotal to how we approach the rollout of long-acting PrEP in the future to come. The main challenge in our setting is that our current PrEP program has been fully demedicalized. PrEP rollout in hospitals has become a rather rare concept among our current PrEP users in Thailand, and yet the existing long-acting innovations are tied to the facilities. We need physicians to prescribe medications, and we need nurses to administer injections. This means that Thailand risks remedicalizing long-acting PrEP, which can limit its access among people with a higher risk of HIV acquisition. However, with this limitation in mind, Thailand has developed strategies to address this important challenge and gap. So now let's discuss the Lenacapavir implementation plan in Thailand. And all credits in the next few slides go to the Division of AIDS and STIs, Department of Disease Control in Thailand, which contributes to the strategic planning of this project. Next slide, please. So, for Lenacapavir demonstration project, Thailand has been selected as one of the target countries under the Global Fund's Grant Cycle 8. And through the Division of AIDS and STIs, Department of the Disease Control, we will receive up to 2,400 doses of Lenacapavir in this upcoming year. During the phase 1 of the implementation strategy, LEN will be distributed through 9 implementation sites in Bangkok, Thailand. The objectives of this pilot and system establishment phases are, firstly, to establish the service delivery model, whether through a facility-based model or a community-based model. Secondly, to advocate for LEN inclusion in the national guideline. This objective has been achieved a month ago after the 2025 updated version of our national PrEP guideline has been published. Thirdly, to establish and pilot the monitoring and evaluation system that is universal and user-friendly. And fourthly, to initiate LEN among 2,400 individuals with the risk of HIV acquisition. And lastly, to generate the early safety and implementation evidences in the country under the real-world circumstances. Next slide, please. So this slide compiles the inclusion and exclusion criteria for those who are eligible to initiate LEN through this demonstration project. As you can see, we aim to access those who are at higher risk of HIV acquisition, assessing through behavioral risk profiles. What I particularly like about this criteria is that we did not target any particular gender identity or limit LEN access to only key populations, but instead we captured the risk profiles, ensuring that LEN will be given to those who can benefit from it. Another learning point here is that we also allow current PrEP users to switch from oral PrEP to long-acting PrEP as well. In my opinion, this strategic decision is instrumental in setting the stage for long-acting PrEP to be an equal option to oral PrEP, rather than a second-line medications for those who failed oral PrEP already. Next slide, please. This slide shows the lessons learned from the early stages of the protocol development and preparation phase of the demonstration project. Firstly, I think what we achieved here is through community involvement. Thailand actively engages community-led organizations in the first phase of the demonstration project, recognizing the community's role in long-acting PrEP rollout. We discussed in detail about the risks of remedicalizing land in Thailand. However, this inclusion helps translate long-acting PrEP from the hospital settings to the community clinic settings. Insights that we will gain from this early implementation will help inform later phases of the project, which aim to scale up LA PrEP in the country-wide level and may support the demedicalization of long-acting PrEP in the long run. Secondly, what we have achieved here is sustainability focused. This demonstration project will include parameter assessments to generate the evidence needed to support the transition to domestic funding in phase 3. Building on our previous experience in supporting oral PrEP within the universal health coverage, this strategic project aims to engage several key stakeholders in the conversations. Again, thanks to Thailand's DDC for developing this plan that focuses on sustainability of the program. And lastly, what we have achieved here is service integrations. The guideline for the land demonstration projects will include free HIV testing and also other sexually transmitted infection screening schemes that will allow clients to receive integrated services along with LEN, proving that the differentiated and integrated care is very much possible through long-acting PrEP. Moving forward. And of course, we need to discuss more about challenges and limitations. The first thing that we need to discuss is equity. The land rollout starts only in Bangkok, which may create an unequal opportunities for those living in other provinces. We acknowledge this, and we know that the next step of the rollout will also include several provinces with higher HIV prevalences. This will help those who could benefit from PrEP in another area or in area further away from Bangkok to assess long-acting PrEP and overcome the barriers of geographical limitations. Secondly, implementation outcomes. Despite the strategic rollout, Thailand has not considered incorporating the implementation framework and outcomes into the plan. What's important about this implementation framework is it will help frame our thinking and capture the essence of what the data that we can gain from this demonstration project and make sure that these frameworks and implementation outcomes can be resonating with other key stakeholders in a policy level, making sure that we can reach sustainability after the first phase of the implementations. And the third challenge is actually the one that I decided to delete from our slides, which is demand generation. The Thailand is in a very unique position comparing to the other Southeast Asian countries, only because long-acting PrEP has been introduced to the community and the general public for quite some time now. We are the only country in Asia that houses the Purpose 2 study, a pivotal clinical research study on LEN use as PrEP. This helps with the demand generations tremendously within the community. And it is reflected through the expressions of interest forms that has been disseminated by the Pripta Tangerine Clinic at IHRI. After we disseminate the expression of interest form into the general public, we received up to 600 signups from only 1 week after the rollout, almost 3 times higher than the allocated slot that our site will receive. This signals a high interest among the community for long-acting PrEP. However, this does not reflect the sustained retention among the clients, particularly when the subcutaneous injections possess such a high level of injection site reactions. So that is something that we need to take a look at in the next phase of our demonstration project. And with that, I would like to thank you for your attentions, and hopefully we can discuss a bit more about this in our panel discussion. Thank you.
Thank you, Fair. I think we don't have a lot on the panel discussions right now. Heather, I'll say if there's one question you want to ask Dr. Boon Rang, what would that be? we will just allow one question to him as the last speaker, because there's a huge amount of chatter in the chats as well.
Absolutely. So I do want to thank everybody who has been asking your questions in the chat and also replying, all of our panelists who have been replying. I feel like there is one question that everybody is wondering about with Thailand. Thailand has a long history of differentiated service delivery. There is a history of programmatic implementation of oral PrEP. However, CAB has really struggled in Thailand. What is one, and I don't think Thailand is unique in that situation. So if you had one thing to say or one piece of advice to give to countries who maybe aren't even as advanced as Thailand is in this, what is the one thing that they really need to do to embed Lenacapavir within choice and within differentiated service delivery models? What is that one enabler?
Thank you, Marie, for that beautiful question. I think the main barrier for CAP-LA in Thailand and in other countries as well is the price, because the government is also very reluctant to take up CAP-LA as part of the universal health coverage because they cannot get the price down, right? And at the end, the level of the medicalizations that the CAP-LA has in comparison to LEN is a bit higher in terms of that the fact that they have to the clients have to come back to the clinic every 2 months, and that makes it much harder for CAP-LA to scale up nationally within our Thailand's context. So I think we can do that in a more sustainable and demedicalizing way through LEN, because LEN is a much more flexible options for a lot of people with the help from other organizations that helps bring the prices down for countries. I think LEN will have a much better chance to be taken up by the government because of these reductions and the level of demedicalizations that we can do. So basically, I think that the strong points here in Thailand, as shown in the slide set that I have presented, is that the government actively includes community-based organizations to the LEN rollout. And with that, I think it's a very good start to make sure that LEN will be circulating in the community rather than being limited in the hospital-based settings.
Thank you, Dr. Fair. I mean, LEN pricing is already cheaper than CAB, and the projected pricing for generic is going to be much more affordable at that $40 to $60 mark. Plus, as you rightly pointed out, the service delivery costs are also a lot less at a twice a year point. So these are all important considerations.
So with this, I would like to thank all the speakers. And although I didn't do it just now, that can all the speakers open your camera so that we can take a picture? This is the first time we are in Asia really talking about LEN and getting cross-regional experience from Africa as well and across the region on this really important and potential game changer if we actually scale up enough coverage and really stop HIV new infections. So Pruvi, you as well, I would like to thank Pruvi Shah, who is part of our team in Seattle, and she's been quietly organizing the webinar and also the slide deck. So thank you. Let me just take a picture all together. Great. So with this, I would say thank you very much for your patience and the 88 brave souls that are still on the webinar. We had over 130 people in the webinar earlier, and they had to drop off. And this is again a very good discussion between the countries and between organizations and communities. So thank you very much, everyone, and thank you for your excellent presentations. And I think, as we say, onward and upward, we are waiting for generic LEN to come to market to get WHO pre-qualified, and most importantly, to introduce and scale, but also the prices. If bulk volume is high, then the prices of LEN will come down, even below 40. That's what I understand. All right. Thank you very much, all. And with this, we close the webinar. Bye. Have a good day.
Thank you. Bye bye.
Bye.